So the time is 1:31 now. We're going to go ahead and begin. We have 136 people, 138, and people are still coming in. So obviously this is a topic of interest. I want to welcome you to today's webinar on the principles for prevention professionals across the MEB spectrum. My name is Derek Newby, and I'm your TTA specialist at the Region 6 PTTC. And I'm delighted to be here with all of you as we explore the essential principles and strategies for preventing mental, emotional, and behavioral health disorders. The field of MEB health is incredibly dynamic and crucial. It's impacting individuals and communities at every level. And as prevention professionals, we play a pivotal role in promoting mental health, preventing substance abuse and misuse, and for fostering overall emotional well-being. So today's webinar is designed to equip you with the knowledge, tools, and insights necessary to enhance your efforts in these areas. And over the next 90 minutes, we're going to cover several key topics. So I encourage you all to engage actively throughout this session and ask questions. Share your experiences, and also to participate in all the discussions that we will have. Our goal is not only to provide information, but it's also to foster a collaborative learning environment where we all can benefit from each other's knowledge and experience. So as we begin, I'd like to extend a special thank you to our support team, Wanda Hudson and Richard Feinberg, for being here with us today and supporting us in our efforts to provide this service with you. In addition to our speakers, this would not be possible without our team. And I want to thank you for all that you do. And your commitment to advancing the principles of prevention is truly inspiring. And it's essential to the well-being of our community. So let's go ahead and get started. This is our acknowledgments. Clearly says that the opinions that you'll hear expressed herein are the view of the PTTC network and do not reflect the official position of the Department of Health and Human Services or SAMHSA. You'll receive a copy of this slide deck in about a week after this presentation. And if you'd like to read the complete acknowledgement, you can do so at that time, but it is here on the screen for you. So, as we begin today, first of all, I want to start by introducing the team of speakers that I have here for you. Sean Byrne is the Senior Training and Technical Assistant Specialist for the University of Oklahoma's Strategic Prevention Technical Assistance Center, which you'll hear referred to from time to time as SPTAC. He's the owner, CEO of the Byrne Center, private counseling practice serving individuals struggling with anxiety and depression and trauma issues. He has written and been awarded grants to work with local law enforcement, doing critical incident debriefings, training of law enforcement peer support teams, and a collaborative mental health law enforcement response team. Sean is a licensed professional counselor, a licensed master of social work, and he's internationally certified as a prevention specialist. And he's also an EMDR specialist, which he'll explain to you a little later while he's doing his presentation. But he's engaged in community and individual change for over the last 30 years. Our other speaker that we have, our primary speaker is going to start off with us today, is Sarah Davis. And she's the Associate Director of the Rocky Mountains Public Health Training Center, housed with the Center for Public Health Practice at the Colorado School of Public Health. The Rocky Mountain Public Health Training Center is one of the 10 HRSA designated regional public health training centers, and she leads a team that provides high quality, primarily distance-based training to professionals addressing public health issues throughout the PTTC region. And she's also supports the national workforce development efforts as part of the Public Health Learning Network. Sarah holds a master's in nonprofit management and has spent the past 20 years in the public health field working as a project and team leader, and also a facilitator and a trainer, and a grant writer, and a manager. Her background includes program planning and implementation, integrating programs and policy initiatives, and working with coalitions. Sarah lives in Denver with her husband and her high school daughter and her two dogs. So we have a great cadre of people here for you today for you to learn from. And thank you for also putting your contact information into the chat for us. We know your name and your organization and cities as well. And we appreciate you sharing that. We will be saving that and looking through it as well, but that helps us to see the audience that we're working with. I see a lot of people on here from Texas, which is a part of our region. For the Region 6 PTTC, we primarily serve Louisiana, Arkansas, Oklahoma, Texas, and New Mexico. So any of those who are here today who are from one of those 5 states, want to make it clear to you know that you are in the Region 6 service area, and we'll be pleased to serve you, as well as we're just happy to have everyone here from around the United States, because this is definitely open to everybody, and this information is going to be relevant to everyone as well. Our learning objectives for today are to describe the core and principles that underpin effective prevention practices across the spectrum of mental, emotional, and behavioral interventions, and also to develop practical skills that enhance your ability to partner with other organizations that you work with across the spectrum, and then to identify some key strategies for applying these principles in diverse settings so that you can serve even greater populations as well. This is our roadmap for today. As we've already started with our introductions and objectives, we're going to talk briefly about the principles for prevention professionals that should also carry you through the continuum. We'll talk about the continuum. We'll talk about partnering with prevention. We'll share resources with you as well. But please do not leave until you do our evaluation. It's not over till the paperwork's done. And we want to definitely make sure that we get your feedback, because that helps us to improve the work that we do for you. So I'll begin by talking with you about the principles of prevention professionals. And I want to start off by saying prevention professionals play a crucial role in promoting mental health, emotional, and behavioral well-being across the MED spectrum. That's just what we do. I'm going to share with you some of the important principles that should help guide your work as a prevention professional, which should always be considered as you work across this spectrum. Starting out, of course, with evidence-based practice. Prevention efforts should be based on scientific evidence and best practices, and prevention professionals should utilize interventions and strategies that have been rigorously evaluated. And I know you've heard this on multiple occasions, but to be effective in promoting positive outcomes, we have to stick with this guideline because it helps us to prevent the negative ones. Of course, we all want to make sure we do no harm at all. Cultural competence in our prevention efforts helps us to be sensitive and helps us to respond to diverse needs and values and experiences of individuals and communities. So prevention professionals should always strive to understand the culture, context in which they work, and then they can tailor their interventions accordingly to ensure relevance and effectiveness. For collaboration and partnership, as a preventionist myself, with over 20 years of experience, effective prevention often requires collaboration and partnership among various stakeholders, including community organizations and schools and healthcare providers, and also government agencies as well. And most importantly, with individuals who have lived experience and are living within the community that's being affected. Prevention professionals should work collaboratively to leverage their resources, to share expertise, and then to coordinate efforts to maximize the impact that they want to have on the community. When it comes to lifespan perspective, prevention efforts should address the continuum of mental, emotional, and behavioral health needs across the lifespan, from early childhood through adulthood and into older age as well. Uh, it's often been said when in my work that we take care of them from the cradle to the grave. It's doing prevention is across the whole lifespan, and prevention professionals should recognize the unique developmental stages and transitions that individuals experience and then tailor their interventions accordingly. Multi-level approach is one that you have to be familiar with because prevention efforts should target multiple levels of influence, including individuals, family, and community, and also the societal factors. We'll expand upon that later. But prevention professionals, they have to address risk and protective factors across each level, and they have to create the environments that support mental, emotional, and behavioral well-being. So, and for all of our work to be worth it, we have to always focus on sustainability as well. It's not enough to come into a community and help them without a sustainable plan as well so that they are able to continue their efforts. And prevention efforts should prioritize sustainability by building local capacity and fostering leadership. We create leaders, whether it be starting people from the time that they're youth, or it be creating leaders that are adults already. But we promote system level change as a preventionist. And prevention professionals have to work to strengthen those infrastructures that exist within communities, develop partnerships, and then secure the resources to support ongoing prevention efforts within the communities as well. For evaluation purposes, as I have heard so many times, again, it's not over till the paperwork's done. Prevention efforts should be evaluated regularly to assess the effectiveness. We as prevention professionals identify areas for improvement in the work that we do because we know there's improvements to be made. And then we use informed decision making as well so that anything in the future learns from the past. And prevention professionals should use data and feedback to refine their interventions and to adapt strategies to change to the changing needs. Overall, you want to maximize your impact over time. And that means we learn as we go as prevention professionals. And all of this should be done ethically. Prevention professionals should adhere to ethical standards, guidelines, and prioritize the well-being and dignity of the individuals and the communities. Prevention efforts should be conducted with integrity and transparency and respect for culture and individual values. So we're looking at our work over a lifespan and understanding that prevention efforts should address the continuum of mental, emotional, and behavioral health needs across the lifespan from early childhood through adulthood. Ultimately, by following these principles, prevention professionals can effectively promote mental, emotional, and behavioral well-being across the MEB spectrum, contributing to healthier individuals, families, and communities. At this time, Sarah is going to talk with you about expanding and exploring the MEB spectrum. Sarah?
Great. Thanks so much, Derek. So the MEB spectrum, we're talking about a conceptual framework that encompasses the continuum of mental, emotional, and behavioral well-being. That's what MEB stands for. And this spectrum was developed by the National Academies of Medicine. This may look familiar to some of you who are familiar with it as the continuum of care. So it's undergone an update in recent years that includes this renaming, as well as the addition of the pie wedges within each part of the spectrum, which are sized differently to represent how resources should be allocated across various different components. So I'm going to go into a brief overview of the parts of the spectrum. And while I'm describing these components, I'd like you to think about where along this spectrum your work takes place. And it might be in more than one place. So let's start off with that yellow section over on the left side of the spectrum. This is for promotion. And this part of the spectrum focuses on general health and well-being. So it's not disorder specific. So for example, strategies on this end of the spectrum are things that promote overall well-being. So rather than being specific to preventing substance misuse, there's strategies that promote healthy lifestyles, positive relationships, resilience, those type of general well-being promotion pieces. Our next section around prevention, which is here in green, are strategies that occur prior to the onset of a problem. So though they don't have to be, many prevention strategies are specific to a particular disorder or unhealthy behavior. So for example, they might work on preventing tobacco use or substance misuse or preventing intimate partner violence. In this section, you're going to see that the wedges distinguish between different types of strategies: universal, selective, and indicated. And we'll talk briefly about this a little bit more later, but this indicates the population that's affected by the prevention strategies. So universal prevention strategies, which you'll see are the largest part of the pie there, are those strategies that impact an entire population. Selective strategies are for those populations who are at higher risk. And indicated strategies are for those populations who have begun to show a sign of the problem behavior. What's important here is that prevention occurs before there's a diagnosis. And then once there's a diagnosis of a problem, we're in the blue section of the spectrum, treatment, which includes identifying and treating the issue. The last portion of the spectrum in purple is maintenance. And here we focus on compliance with long-term treatment to prevent likelihood of relapse, and it also includes rehabilitation and recovery support. And then finally, you'll notice that gray arrow that runs along the bottom of the spectrum, and that emphasizes that promotion strategies, those strategies that create a generally healthy environment, that those are important across the entire spectrum. So let's take the example of having access to outdoor recreation spaces. That's a promotion strategy that promotes general health and well-being. And that not only helps prevent unhealthy behaviors, but it's also helpful for those who are in recovery. So that's why we see the promotion arrow across the bottom of the spectrum. So why is the MEB spectrum important? It offers us a visual representation of what we want to have available to our community. It's a reminder that we want to have all of the different pieces of the spectrum, and that we need to invest in promoting healthy environments, preventing disorders and unhealthy behaviors, treating illness, and also supporting people in recovery. So let's do a little bit of an activity so we can discover where each of you are along the spectrum. So we're going to do an annotation activity. So this is going to allow you to stamp on the slide here. So the first thing you're going to do is go up to the top toolbar on your Zoom screen where it says you're viewing my screen in green, and you're looking for the pencil that says annotate. And if you don't see it, you might click on that option that says more, and you're looking for view options, which will bring up some other options. So you're looking for the pencil that says annotate. You'll click on that, and then next you'll have an option to click a check mark to make a stamp. And go ahead and pick the heart shape and practice stamping in this gray area over here. Yeah, awesome. Seeing the stamps pop up, that's great. Many of you have done this before. We'll give folks another second here to practice finding their annotate. And if you're not able to annotate for whatever reason, feel free on the next slide, you can drop your answer into the chat if annotate isn't working for you. All right, so let's pause your stamping. And Richard will help clear those stamps out for us. And we'll go to our next slide. All right. Okay, so what I'd like you to do now is place a stamp along the continuum for where your work occurs. And we've got a lot of folks, so I'm guessing we're going to cover this continuum up. So I've got lots of folks coming in around promotion and prevention. A few folks around maintenance for long-term treatment. Great. Yeah, and you may find that your work covers more than one part of the spectrum here. This is great. So this is what we might have anticipated for the audience on this call is a lot of us are working in that upstream prevention, health promotion space. Some of us also working in the treatment or recovery and maintenance space as well. And see a few folks dropping into the chat as well, which is great. Thank you. All right, so let's pause the annotation here and we'll go ahead and clear the screen. So I want to highlight a few of the terms that we've been using, starting with mental, emotional, and behavioral health. So first of all, mental health refers to a person's psychological and emotional well-being. So we're talking about their cognitive function, emotional regulation, resilience, their ability to cope with stress and adversity. So optimal mental health enables individuals to function effectively in our daily lives, maintain fulfilling relationships, achieve our goals. Emotional health involves recognizing, expressing, and managing those emotions in a healthy and adaptive manner. So it includes things like self-awareness, empathy, emotional resilience, our ability to regulate our emotions effectively. And when we are emotionally healthy, it influences how we perceive and respond to stress, relationships, and life challenges. And then finally, behavioral health focuses on the patterns of behavior that impact health and well-being. So this encompasses a wide range of behaviors, including those related to substance use, eating habits, exercise, sleep, interpersonal relationships, all kinds of things. And positive behavioral health involves adopting healthy behaviors and making choices that promote physical and mental well-being. So when we have folks who are experiencing their optimal mental, emotional, and behavioral health, they have a sense of well-being, resilience, they're able to respond positively to challenges, they're able to seek and find fulfillment in their lives. So optimal functioning, characterized by positive emotions, healthy coping strategies, and effective problem-solving skills. All right, so what we're going to do now is overlay some of these additional terminology, some additional terminology that you might be familiar with, and make some connections to the MEB spectrum. So the video that we're about to watch describes the difference between primary, secondary, and tertiary prevention. And as you watch the video and hear the descriptions of these types of prevention, again, I'd like you to be thinking about where they would fall in the work that you do, as well as where they would fall in the mental, emotional, and behavioral spectrum.
How do you support individuals in achieving their highest level of health? What role do you play in creating healthy, thriving, resilient communities free from substance abuse, violence, or suicide? This short video will take a look at prevention, break down some terminology, and help you see where you fit in. Let's start with a story. Imagine if you saw someone in your community fall over the edge of a cliff. You would probably be relieved to find an ambulance at the bottom, ready to whisk them off to be cared for. Now imagine if you saw it happen again and again and again. You might ask, how can we catch them before they get to the bottom? And then maybe you'd work with other people in your community to put up a net to catch people before they hit the ground. But the net you put up is not perfect, and some people continue to fall through the cracks and around the edges to the bottom. You realize that you need to do something to prevent people from falling over the edge in the first place, so you build a fence at the top of the cliff. As you are admiring the new fence, you start to notice something else. Some people in your community are living right on the edge of the cliff and are still at much greater risk for falling, even with the added protection of the fence. You start to wonder why it might be that some people are so close to the edge while others are farther away. Now let's take a deeper look at this story. There are many social, economic, and environmental factors that impact our health and the choices that we have available to us. Factors within our families, schools, and communities can serve to protect us or to put us at greater risk. When we live in an unsafe area or face violence at home, when we don't know where our next meal will come from and have few job options, when we face discrimination or are isolated without social support, when we have little connection to school or have experienced academic failure, when we don't have a trusted adult in our lives, or when it's easy for us to get drugs, we are in effect living at the edge of the cliff. Tackling these shared risk and protective factors, or social determinants of health, is considered upstream prevention. We are moving people away from the cliff's edge and reducing their risk for violence, substance abuse, suicide, teen pregnancy, dropping out of school, and more. Our fence represents primary prevention. Some examples of this might be a mentoring program that teaches parenting skills or helps young people develop coping skills. It might be a policy that raises the age to buy tobacco or adds a health class in our schools. These efforts seek to do things like stop violence before it occurs, prevent a young person from using tobacco, marijuana, alcohol, or other substances, or to support a student before they drop out of school. If we could prevent everything, that would be great. But we know that's not the case. This is where the net, which represents secondary prevention or intervention, comes in. Something negative has already happened, and we're looking to help get things back on track or to intervene and prevent them from getting worse. Examples might include a diversion program, a collaborative management program, or screening efforts. And even with all of these in place, we know we need treatment facilities for those struggling to overcome addiction, hospitals for those suffering from injury, and jails for those who have committed serious offenses. This is referred to as tertiary prevention, and it has the goal of rehabilitation, preventing death or future offense. To be successful, we need a comprehensive approach, one that complements treatment and intervention services with primary and upstream prevention efforts. Regardless of where your day-to-day work focuses, we all have an interest in seeing kids and communities live and thrive away from the cliff's edge.
Great. All right, so hopefully you were seeing some similarities there between concepts that were explored in the video and this MEB spectrum of prevention that we were just talking about. So what I'd like you to do is drop into the chat where you think along the MEB spectrum does tertiary prevention fall. So in the video, tertiary prevention was represented by the image of the ambulance at the bottom of the cliff in the video. So type into the chat where you think along the MEB spectrum tertiary prevention falls. Great, seeing lots of treatment and maintenance. Yes, absolutely. Great. All right, so how about secondary prevention? So this was the image of the net in the video. Where on the MEB spectrum does secondary prevention fall? Go ahead and type that into the chat. So seeing a few preventions, seeing a few treatments. Rebecca mentions indicated prevention. Excellent. Case identification and treatment. All right, we've got a sharp group here. So secondary prevention falls right there, a little bit in prevention, a little bit in treatment on the early side of treatment. And then what about primary prevention? Where does this fall on the MEB spectrum? Where does primary prevention fall? Excellent. Promotion, universal prevention. Yes, promotion and prevention. Yes, right on target. So we wanted to share both the MEB spectrum and that video that brings in these concepts of primary, secondary, and tertiary prevention because we recognize that folks use different types of terminology. And what's important more than the term that you use is an understanding of how these terms fit together and really what kind of strategies fit within each of these. All right, so that's what we're going to dive into next, is looking at some of the strategies and some of the core principles related to each of these sections of the MEB spectrum. So we're going to start with primary prevention, talking about promotion and prevention. And in our cliff video, those were the strategies like the fence that kept people from falling off the cliff, as well as the upstream strategies that moved people further away from the cliff's edge. So promotion and prevention are about intervening before a disease or condition occurs. And we're going to cover three core concepts in primary prevention. First being risk and protective factors, population-based approaches, and then we'll also talk about policy and environmental change strategies. And Kelly, I see your question in the chat about the video, and yes, we'll make sure that there's a link put into the chat for the video so that you can access that as well. All right, so let's talk about risk and protective factors first. Risk factors are those characteristics. They can be biological characteristics, psychological, they can be at the family, community, or cultural level, and they're things that are associated with a higher likelihood of negative outcomes. Meanwhile, the flip side of that are protective factors, and those are characteristics that are associated with a lower likelihood of negative outcomes or things that reduce a risk factor's impact. Risk factors can be, or protective factors can be seen as positive counteractive factors to risk factors. And as Derek mentioned in his introduction about the principles of prevention, risk and protective factors for substance misuse change over the lifespan from infancy to adulthood, and they occur at the individual, family, community, and societal level. So that's why we have this image up of the socio-ecological model, reminding us that these factors occur individually as well as within our family, the community, and the society at large. So let's look at a few examples here of risk and protective factors. So examples of risk factors for substance misuse are written in red here, and they include things like being exposed to alcohol in the womb. So this would be an example of a risk factor that happens at the individual level in infancy. Another risk factor would be parental modeling of drug or alcohol use. So when young people see their parents or close family members using drugs or alcohol, that's an example of a risk factor that happens at the family level. Meanwhile, protective factor examples for substance misuse are in green, and they include things like families, when they have adequate financial resources, that's a protective factor that happens at the family level. Another one, young people who have positive experiences with teachers or young people who are connected with adults outside of their family, those are community level protective factors. Another example, policies that limit access to alcohol are another protective factor example, one that occurs at that society level. So again, we're seeing examples from infancy to adulthood of risk and protective factors, and ones that start at the individual level all the way up to the community and societal level. So many effective primary prevention strategies focus on reducing risk factors and or increasing protective factors. So if you've done prevention work that works specifically on reducing a risk factor or increasing a protective factor, go ahead and put a heart emoji in the chat, or use your reaction button at the bottom of your toolbar and give us a heart to let us know if you're somebody who's worked on risk or protective factors before. Great, seeing several folks. Jenny, Emily, Shelley, Julie, lots of folks. Stephanie. Good, lots of folks working on this already. Excellent. So a lot of our prevention practices work on risk and protective factors. So we're going to be putting a few resources into the chat so you can learn more about evidence-based strategies that address specific risk or protective factors. We gave you a few examples here on the screen. One of the resources that we're putting into the chat is Blueprints, which some of you may be familiar with. And on the Blueprints website, you can actually search for evidence-based strategies based on a specific risk or protective factor that you'd like to address. So that's one way that you could go about finding evidence-based strategies. All right, so we'll clear those annotations out as we talk about some population-based approaches. This is another component of primary prevention strategies, is that they're largely population-based rather than being focused on a single individual. And population-based strategies are strategies and interventions that target entire...
Did you know that they've changed the terminology continuum of care to spectrum?
Is that they target an entire population with the aim of improving health outcomes on a large scale. So we mentioned the terms universal, selective, and indicated earlier when we were talking about the wedges of the prevention section of the MEB spectrum earlier. And some of you may also be familiar with this image of the pyramid, the universal selective indicated pyramid, which shows those universal prevention strategies as the largest base of the pyramid. And universal prevention strategies are population-based strategies. They're offered to the entire population regardless of their level of risk. So a few examples of these that I think will feel familiar. One example would be a social emotional skills curriculum that's offered in a school. So if it's implemented throughout the entire school population, or maybe it's the entire third grade of a school who gets this social emotional skills curriculum, that's a population-based universal prevention strategy. Media campaigns are other examples of population-based strategies because they're reaching entire populations. Policies such as drug-free campus policies, smoke-free park policies. These are other examples of population-based universal prevention strategies. Would love to see some other examples of strategies that fall into these population-based universal prevention strategies that other folks are working on. So feel free to drop some of those into the chat. Other examples of universal population-based prevention strategies that you're doing. So as we look for some of those to come into the chat, family parenting workshops, great. Responsible retailing, yeah, so talking about some of these policy strategies as well. Jenny and Ann mentioned some of these alcohol excise tax work, social norming campaigns, great example, Shelley. So let's talk about some of those other policy and environmental strategies. And these are strategies that seek to make change on the large scale of a community. So impacting community norms, regulations, the access or availability of substances. And you might hear these referred to as policy systems and environmental changes, or PSE changes. And these are universal primary prevention strategies that can be implemented in a school or workplace environment, as well as across an entire city or county or the entire country. So you'll see a few examples here and some other ones in the chat. Zoning laws that limit the number of liquor or cannabis retailers in an area, or limit how close they can be located to a school, for example. Regulations on where liquor, tobacco, or cannabis advertising can be. Raising the minimum age to buy tobacco. Policies that make certain events alcohol-free. Any of these are examples of using policy and environmental strategies. And what these do are they make drugs or alcohol less available or less visible. So they change what we see, they change the environment that we're in. And these strategies, again, they're population-based approaches. They affect the entire population rather than an individual, and are examples of universal strategies. So feel free to drop any other examples that you want to of policy systems or environmental changes that you're working on. I see some great ones in the chat. Gabby mentions increasing fines for stores that sell alcohol to underage. Yeah, so some great examples in the alcohol excise tax. That would be another example of a policy change. Substance-free housing at colleges. Reducing advertisement on cannabis to cannabis or liquor retailers, absolutely, or limiting where that advertising can occur. Great examples. So we'll drop a few more resources into the chat if this is something that you'd like to explore more about. We're going to move on to secondary prevention. So in the video, this is represented by the net. And in the mental, emotional, and behavioral health spectrum, it falls under indicated prevention and those early parts of treatment, so case identification in the treatment part. Secondary prevention is about halting or interrupting substance misuse behaviors by intervening with individuals who are demonstrating early signs or symptoms of misuse. So you'll hear intervention used a lot here. A few of the pieces we're going to dig into here: early interventions for substance misuse aim to identify and address problematic substance use before it escalates into more severe issues. We're going to look at identifying issues early through screening and assessment. And then we'll talk a little bit about culturally responsive interventions as well. So early intervention programs are examples of secondary prevention. So something's happened, underage drug or alcohol use has occurred, for example, but we're not to the point of having a diagnosed condition. So we're not to the treatment part of the spectrum. There's still an opportunity to prevent misuse from happening. So examples of these early intervention strategies could be things like an alternative to suspension program for young people who have violated a school policy. So instead of being suspended from school, which could have negative educational consequences, they're instead participating in an educational alternative to suspension program. Similarly, a diversion program might be an option for a young person who's found in possession of substances, who's committed another crime. Instead of being involved in the justice system, they might have an opportunity to participate in a diversion or a restorative justice program. And the second two prevention strategies that we just talked about serve a couple different purposes. One is that intervention before serious drug use or misuse occurs. And the second is providing opportunities for educational or pro-social opportunities, both of which are protective factors. So rather than a punitive measure that might have other unintended consequences, such as missing school or becoming involved in the justice system at an early age, we're able to counteract by providing some protective factors as well. So we're going to drop a few more resources into the chat, again, just so that you're able to dig into any of these areas that you may be less familiar with. The next piece that we'll talk about is screening and assessment as another secondary prevention or intervention strategy. And screening tools can help identify individuals who might be at risk for substance misuse. These assessments can be conducted in a variety of different settings, including schools, healthcare facilities, workplaces. A specific strategy that you might be aware of is called SBIRT, which stands for Screening, Brief Intervention, and Referral to Treatment. And conducting SBIRT is another example of that safety net. So something's happened, and you're able to conduct some screening to assess the level to which the behavior is occurring and any related problems that might be coming up, and then take action based on that. So you'll see in the flow chart on the right side of the screen that the screening helps to determine the action that should be taken based on the level of alcohol or drug use that's occurring in this example. So with moderate use, you might implement a brief intervention using some motivational interviewing approaches. MI, if you're not familiar with it, motivational interviewing, it's a client-centered counseling approach. It helps individuals explore and resolve any ambivalence they have about changing their substance use behaviors. It's really very self-oriented, so it emphasizes empathy, collaboration, autonomy. It's about individuals finding their own motivation to make a change. So you might have a brief intervention is what's called for. Meanwhile, if something more significant, if more significant use is assessed, then you might be making a referral to treatment in that case. And the last piece we'll talk about here in secondary prevention is around providing culturally appropriate interventions. And really, this is important across the MEB spectrum. We're going to talk about it here. It's important to recognize that demographic groups, for example, new Americans, so individuals who are new to this country, LGBTQ+ individuals, people of color, many marginalized communities often have unique risk and protective factors and other determinants of health that impact their use of substances. So, for example, someone from a marginalized group may face increased discrimination, increased social isolation, both of which are risk factors to substance misuse. On the other hand, individuals might also have important protective factors that come from being part of a close-knit family unit or a faith group or cultural beliefs that help prevent substance misuse. So when we're trying to intervene and disrupt an unhealthy behavior, when we're able to do so in a culturally responsive way, that's critical to the success of the intervention. We want to provide interventions that are aware of and responsive to individuals' cultures, that are attuned to language needs, cultural values, historical trauma, experiences of discrimination. When we are able to do that in a responsive way, we're more likely to be successful with our interventions. And with that, I want to pass it on to Sean to talk about treatment.
All right. Thanks, Sarah. Okay, so I have the fun of talking to you all about treatment. And this is when that fence didn't work, that net didn't work, and the individual is at the bottom of that hill, and we're driving the ambulance up. Now, an interesting thing happens at this point that we have to deal with, and we have to be real that this is an aspect of this. We have stigma at this point. When an individual is at that treatment, that tertiary prevention level, unfortunately, our society, our communities start stigmatizing that. So much so, I don't know. I saw in the chat that there were several of you from Oklahoma. I'm not sure how it is in other states, but did you know that at one point in the state of Oklahoma, if you were running a substance abuse treatment facility, you could not be located within 1,000 feet of a school or a church? Now, that's very blatant stigmatizing of our population that we're working with. And it's interesting, though, because I did some research, and you know what isn't prohibited from being near a school or a church? Criminal defense attorneys, individuals who work with people who have literally broken the law. But there's not as much stigma with that as there is with our population. So when we talk about this, and because I think this is real important for us to remember, because it's not just as easy as going, well, we just move these people into treatment. Not sure what your states look like, but in the state of Oklahoma and in other states that I've been involved with, there's oftentimes a waiting list to get people into services. So put in the chat, if you can, what your perception is about how long it would take to get someone into an inpatient facility. And we're going to see if I can advance these. Yes, I can. Okay, so this is some of the stuff that that falls under that tertiary prevention: treatment and recovery support, harm reduction. Someone had asked earlier where harm reduction falls in this. And so harm reduction falls into the tertiary treatment after something has already happened. And I'm looking at the chat out of the corner of my eye over here, and guys, I'm getting depressed. Okay, I'm seeing some of you say 2 to 3 months. I think someone said 6 to 8. I couldn't tell if that was weeks or months. Now, well, let me skip to the next slide real quick, because I'm gonna get on a little soapbox real quick about this, and hopefully you all bear with me with that. So when we talk about treatment and recovery, one of the first is inpatient rehabilitation. Now, when we're looking at mental health, we don't call it rehab. We just call it inpatient treatment. Rehabilitation is typically a term used when it comes to behavioral or chemical addictions. When we talk about behavioral addictions, the Diagnostic and Statistical Manual has started adding in behavioral addictions. Gambling addiction is the first one that's been added in. So sooner or later, that may be something that we end up engaging with at the prevention level and the treatment level. I'm not sure. But I'm seeing you all say it's taking 3 months, 6 months, 6 to 8 weeks. Even I think the lowest I saw was 30 days. If someone is at that point where they're going, I need help, I've recognized that through the use of motivational interviewing, which, believe it or not, all of you can be trained in motivational interviewing. It's not just a clinical technique. The insurance salespeople that I know, all of them have been trained in motivational interviewing, interestingly enough. But someone's used motivational interviewing and they've gotten this person to the point where they're going, yes, I need treatment. And yes, we've identified that inpatient treatment is the level of treatment that they need. And now you're telling them that they have to wait 3 months. Are they still going to want treatment after 3 months? Are they still going to be in that same headspace? The answer is probably not, almost definitely not. And I see people in here putting detox also. We have to understand that when we're talking about certain types of chemical addictions, a detox may be the first step to inpatient treatment. especially when it's something like alcohol, individuals need a chemical detox off of that substance so that they are medically stable to begin inpatient treatment. We always want the lowest level of the lowest restrictive environment possible, least restrictive environment. Um, Now, with mental health, that typically indicates that the individual is a danger to themselves, a danger to others, or unable to care for their own basic needs. But when we're talking about substance abuse, why might we want someone to go inpatient? Why might we want to take them out of the environment that they're already in? Some of you throw some suggestions in there in chat as to why that might be important to start off with either an inpatient or a residential. When we're talking about acute inpatient, we're talking about typically, yep, I'm seeing it. Acute inpatient is typically a matter of days. Residential can oftentimes be weeks or months at a time. I say weeks, that's still acute. But in some states, residential might be considered weeks at a time. It's Yes, I hate it when people are told services are available, but they can't get there. Absolutely. Absolutely. So sometimes we want to get the person out of the community because the triggers for their use, the availability of their use is there in the community. Um, After inpatient, then we're going to look at outpatient treatment. Outpatient treatment can be anything from individual counseling services, group counseling services, um, support systems. Alcoholics Anonymous often isn't considered treatment, but it is a support group system that has a lot of validity. And whether your client is geared more towards the Alcoholics Anonymous or the Celebrate Recovery or some other model, different models work differently for different people. So it's helping the individual attach to that model or to that modality that works best for them. And as preventionists, what we can do, I think one of the most important things for preventionists to do is not to increase the stigma. Any of you that were around in the 80s, you know that stigma was a part of prevention back then. Any of you that have ever been involved in tobacco prevention recognize that unfortunately stigma was a part of that. Remember Mr. Grossmouth? And who wants to kiss the mouth of a smoker? So what we're doing is we're pushing these people that have already fallen off that cliff further and further from the treatment that they may need because we're isolating them and we're stigmatizing them. So we want to make sure that that's not a part of what we do. And then we're going to look at medicated assisted treatment. Preach. Yes, Courtney. I get on my soapbox. Someone asked earlier about harm reduction. Medicated assisted treatment can fall under treatment or it can fall under harm reduction. When we look at the medicated assisted treatment that falls under the treatment modality, we're looking at things like Camprol, like Antabuse, like naltrexone, things that help an individual to decrease the symptoms of the detox so that they can engage in treatment. Or Antabuse has a different role. We don't have a lot of time to talk about that. Or for opioids. You have the opioid agonist drugs that are used to help an individual who may be suffering from an overdose. I saw that there were Narcan, that there's people in here from Narcan distribution service providers. We're going to talk a little bit about that. Narcan vending machines in Oklahoma now. Yes, yes, yes. Now, while Narcan is a rescue drug, things like Suboxone is a harm reduction drug. Suboxone is something that individuals may need to be on long term, and it doesn't necessarily treat the individual. We're not getting them off of opioids, but we're putting them on a less dangerous drug intervention. Okay. So, and some of you are ahead of me in chat there. You all are jumping on this. Okay, so yeah, so now we talk about harm reduction. Fentanyl test strips. I see that there are people in chat that are familiar with fentanyl test strips. Um, Fentanyl test strips are test strips that you can use with any other type of drug that you may be using to detect the presence of fentanyl. Fentanyl is a highly, highly powerful opioid. For those of you who don't know, small amounts with individuals who haven't built up a tolerance can create an overdose very, very quickly. So
Sean, you have a
it's
question in the chat. Is the
yes.
act of distributing naloxone tertiary?
Ooh, that's a very good question. The act of using naloxone is tertiary, but can the act of distributing naloxone bring awareness and knowledge about an opioid epidemic, and where would that fall, right? So when we look at the interventions, they can fall under multiple domains depending on our frame of reference to that intervention. And depending on how good you are at grant writing, right? How you put that down in that grant's going to matter a lot. But a lot of these things can be seen from different perspectives, and they can fall into different categories. Obviously, Narcan with someone who's had an opioid overdose is definitely tertiary prevention. We are preventing death at that point. And I see prescription disposal and lock boxes. Absolutely. Tertiary prevention is the prevention of the worsening of that addiction, which the lowest bar to that is we're preventing death. Okay. People don't recover who are dead. All right. And I know that there's, again, we talk about stigma, and I work with law enforcement officers. And sometimes law enforcement officers have inherent stigma when it comes to individuals who use substance abuse. But the reality is, if we can save their life, now we have a possibility to get them in treatment, get them in recovery, and get them clean and living their best life possible. So naloxone, Narcan. I'm going to take up a little bit more time than I did during our test run on this, guys, because there are people in here that know about Narcan, but there are people in here that don't. So Narcan is a rescue drug. It's in, I don't know if you all can see that. It looks like a nasal spray. You pop this out of the packet for someone who's having an opioid overdose, you shove it up their nose and you plunge it. Now, let me ask you all in chat, what happens if someone isn't having an opioid overdose and you use Narcan? Does their head explode like, those children of the 80s, like the movie Scanners? No, nothing. A wet nose. Yes, you got wet boogers, and that's it. If you use Narcan on someone who's not having an overdose, nothing happens because it binds to the opioid receptors of the brain. So if there's not an opioid molecule on that receptor, all you got is real clean opioid receptors, okay? Nothing's going to happen. So never be afraid to use this. I have one of these with me at all times. I've got them in my cars. I've got them in my briefcase. You never know when you're going to need it. Advocating for it to be in places like golf clubs, YMCAs, daycare centers. I don't care. Walmarts. If there's a large group of people, you need to have Narcan available in that place, the same as you do the shock paddles. Sorry, I'm drawing a blank on what those are called at the moment. It's important, and this helps reduce the stigma also. So, and then we get into syringe exchange programs, which I know are illegal in some of your states, but that's a prevention program also, is working on changing those policies, changing those laws to allow for syringe exchange programs. Whoops, well, I can't hit that button because that doesn't work. So, relapse prevention. Cognitive behavioral therapy is listed here under relapse prevention, but cognitive behavioral therapy is a treatment modality. When we talk about it as relapse prevention, what we're talking about is the think, feel, do cycle. And it's identifying the triggers that we may have that cause the thoughts of use and then move into the behavior of use. Now, please, please, please do not misunderstand me with this. I've worked in the treatment field now for over 15 years. I've worked with substance abuse addiction, behavioral addiction. We cannot eliminate all of the triggers in someone's life. Not only is that not possible, but that's not ethical. Okay. Now, some of what you do in primary prevention, limiting advertising, limiting alcohol outlet density, that can help individuals who are in recovery because it decreases their triggers. But what we have to do is we have to work on that individual to desensitize them to those triggers. Because a trigger isn't necessarily just the alcohol, tobacco, or drug. A trigger could be a 7-Eleven. A trigger could be a smell. It could be any number of things. So we work with them, and that's part of what we don't have time to talk about EMDR, but that's part of what we do with EMDR also is what's called the deter method, desensitization to triggers and urge reduction. Um, Mindfulness-based relapse. Now, some of you may have heard stuff about mindfulness. Mindfulness isn't any, weird, out there type, practice. Mindfulness is simply being aware in the moment and living in this moment. Because when we let our brains float too far to the past or too far to the future, we have no control over that. Where our control lies is in the present. So mindfulness is the practicing of being 100% in the present moment where we do have control. And we can use relaxation techniques. We can use grounding techniques. There's all sorts of different techniques that clinicians can use one day at a time, one moment at a time. I see someone just put in chat. Amen to that. That's a mindfulness technique. I am living in this moment. I am sober in this moment. And then support groups. Support groups don't have to be formal support groups like AA, NA, Celebrate Recovery. Support groups can be families. It can be new sets of friends. It can be a car club, a bowling league. Just individuals who recognize the struggles that an individual may have and can provide support in that moment. Okay. All right. So no, Derek, I turn it back over to Derek at this point. See, I got it right this time. I'm going to turn it back over to Derek to talk about promotion.
Well, thank you, Sean. The audience seems to be very enthusiastic and intent on things that you talked about. This is a very informed audience, and I just want to commend you guys on the work that you're doing, and especially those prevention professionals that are out there. I call you my peers because we are all in this together. And by being all this in this together, we also understand that promotion, and that's what I want to bring attention to as we look at this slide, it occurs across the whole spectrum. Promotion involves the interventions, the programs, the practices, your environmental strategy. Promotion is always taking place and forever. It enables people to increase control and over their lives and also to improve their health. As such, interventions that promote health occur independently as well as throughout the continuum of care as part of prevention. And that's why you see it like you see promotion as its own part of the pie, and also it encompasses the whole spectrum as well. The focus of promotion is on well-being with a goal of enhancing people's ability to achieve developmentally appropriate tasks. We want people to acquire a positive sense of self-esteem, of well-being, of social inclusion. We want to erase stigma because when people strengthen their ability to cope with adversity, emotional well-being allows people to realize their full potential as human beings and to cope with stresses of life and to work productively and to make meaningful contributions to their community. And that's what we want to see as preventionists. We know childhood experiences can have a lasting impact. We've all heard the ACEs study. But promoting wellness in the early years, and that's why we do so much work with youth. It helps to build a foundation for overall health. And I just want to emphasize that so you understand that, like, when it comes to promotion, you can't do enough work in this area. You work with the family, you work with the community, you work with changing society as a whole. And that takes promotion. We have to make people aware of the work that we do. We have to continue the work that we do. And we have to ensure that promotion is always occurring in community. It may be the first step, but it definitely has to be a step that continues throughout the course of the the MEB spectrum. So with that, let's do a little check-in and see what we remember. I want to launch our first poll at this time. And the question is, screening for alcohol use and referral to treatment is an example of what? Is it treatment? Is it primary prevention? Or is it secondary prevention? And okay, thank you for everyone for participating. Questions are coming in. Any of my other speakers here, my colleagues, feel free to step in as we get these poll results in.
Absolutely.
Feel that there's an area where you really need to step in and emphasize something that maybe someone didn't get. So
yeah. Derek is pointing out that I skipped something when I was presenting, and he's doing it in a very polite way. The difference between screening and assessment that falls into indicated prevention. I want you all to think of something like the SBIRT, screening, brief intervention, referral, and treatment. Those of you who may know something like the PHQ-9, the Beck Depression Inventory, those are all screening devices, as opposed to when we move into treatment, and I would even say kind of case identification, we're talking about the provision of a diagnosis. So the addiction severity index, a biopsychosocial, something that a licensed clinician would be doing that results in an actual diagnosis and treatment plan for the individual. Thank you for pointing that out, Derek. Sorry about that.
It's my pleasure, Sean. So just looking at the results here, about 20% of you said treatment, 31% said primary prevention, and then 50% said secondary prevention. And the correct answer is 3, secondary prevention. So for those who chose treatment or primary prevention, I think you just need a little more clarification, and maybe if you, but know that screening for alcohol use and referral to treatment is an example of secondary prevention. And what is that secondary prevention level is? Primary is before they've fallen off the cliff. Secondary is that safety net to catch them. Are the results for you to see. And our next question I have, number 2, intervening before a disease or condition occurs is considered primary prevention. Keyword being before a disease or condition occurs. Is it primary, secondary, or tertiary? Before a disease or condition has occurred. 4. Okay. Now I'm going to end the poll right now. We got 90% of you, 89% got that correct. And the correct answer is primary prevention. Remember the keyword being before a disease or condition occurs. Before. Our third question for you is the type of prevention program that impacts the largest number of people. The largest number of people is indicated, selective, or universal. The largest number of people. Okay. Looks like everyone got this one correct. Okay. Everybody, we're on the same sheet of music here. Changed a little bit. Well, 94% of you got it correct. But that is universal. Remember the universe. So when you think about the type of prevention program that impacts the largest group, think about the whole universe. And the universal. C is correct. Okay. Thank you for participating in that check-in activity with us. I want to talk briefly about the implications of the MEB spectrum, and simply to say that recognizing the MEB spectrum, it really highlights the importance of prevention. and early intervention efforts to promote the mental health and emotional behavior. And we know this is a new concept. You recognize the spectrum, but now it has a new name, but understand why. It's about recognizing the importance, and that's why the name I think was changed. So it emphasizes holistic approaches. The MEV spectrum emphasizes the interconnectedness of mental, emotional, and behavioral health with physical health and social factors. The holistic approaches, that's that well-being. We consider that whole person, and we address the complex interplay of biological, psychological, social, and environmental factors. Yeah. Like it's not just where a person lives; they're also impacted by their biological. What are they made of? What's their DNA? What's in there? Their psychological. What things have happened in their life as well, and then social. What things are constantly going on in their person's life and the environment in which they live as well. So whole health community initiatives, they amplify holistic approach to prevention. I worked for many years at what was called a comprehensive care clinic. And in that clinic, people came in and we looked at the holistic approach. We not only were they there for medicine, but we also looked at social services for them. If they were unhealthy and they needed medication because they were unhealthy, well, how do we get them some food? Maybe they don't have enough food to eat or the right foods to eat. And then how's that affected them emotionally and as well? So we tried to get them into some counseling as well, and then have people to come on and talk to them about finding jobs. And so we looked at the complete whole person, and we tried to improve that person. If they walked in our door from they were supposed to leave out with the resources that they needed to make improvements, so they didn't have to continue to get sick over and over again and end up back in the clinic. It also talks about stigma, of course, some of the implications of the spectrum. We now have an understanding that the MEB spectrum helps reduce stigma surrounding mental illness. And for so long, we had to deal with that. And now that we have something where it's going to be normalized, it's just much better. Like no one looks at you like you did something wrong if you broke your arm and show up at the hospital. They just want to fix your arm and get you into a cast. But also they have to look at like, did you break your own arm, or are you working a dangerous job and that's what's causing you to, is it the environment that's causing your arm to get broken over and over and over again? So the healthcare system for so long has done things like that. You just can't keep showing up with your child sick in the hospital and they not eventually step in and say, wait a minute, what's going on with their environment? Is there black mold in your home? Do you live in an environment where you don't have heat or you don't have gas to keep you warm? What's going on at home that's continuing to cause this to happen? And it emphasizes that mental health is fundamental. It's a fundamental aspect of our overall health. I used to ride motorcycles all the time. I always wore a helmet. And the reason why is because I wanted to protect my mental health. Like I may be able to get my arm fixed, but if I break my brain, then I'm going to have some serious issues. So that was one of the reasons why I wore a helmet. But I also talked with my fellow riders and members of my little club about the same reasons why, to try and increase their uses of helmets as well, because the state doesn't always tell you have to wear a helmet. But you know what? If your friend is telling you like, hey, we need to do something to protect your mind, you're more likely to listen. And I think all of us as preventionists, we don't talk about drugs in the light now of like they're bad. Don't do drugs because they're bad for you. We try to nail it down and run it into their minds that like in order to protect your mental well-being, you may not want to use mind-altering substances because this is the long-term effects of it. So our mental health is extremely important. And we all deserve support when it comes to our mental health. Our providers need to talk to us about this as well as us talking to each other. And then, of course, the individualized care and support. So recognizing the diversity in our experiences and then respect for each person's unique strengths and needs and their preferences as well. We have to treat people like they're individuals and we have to provide care for them that's supportive. Work of prevention is not ours alone. It crosses into many different settings. And I was so happy to see when you are able to put on the screen and indicate which area of the spectrum that you're working in, because that shows that we not only did we reach a diverse audience, but it also gives you the opportunity to see where each and every one of y'all can work together in order to do this. We're more effective when we are together. And one aspect I'm particularly interested in is exploring is a community opportunity for partnership across various sectors to enhance our prevention efforts. Because by collaborating with healthcare providers, educational institutions, community organizations, and other workplaces, we create a comprehensive approach to policy and prevention in multiple sectors. So let's start by looking at the schools, and then Sean's going to talk with you about another sector, and then Sarah's going to follow up as well on this section. So when I talk about schools, I'm talking about opportunities. When you look at schools as a preventionist, there are opportunities for school-based health centers for you to work with those school nurses as a prevention professional and help them to decide which evidence-based programs are going to work best within their school setting. You have an opportunity to talk with the teachers about the health curriculum as it's being taught, and how they can include prevention in there as well. And then most importantly, school policies. We've seen a lot of success with prevention professionals working to help establish school policies, particularly here in Arkansas, where I live and work. There were the vaping problem came up, and there were so many youth vaping, and they were suspending them and taking their vape pens away. But they were already addicted to the content of the vape tools. So we were able to talk with them, help them change their policies and realize the error in their ways, and they were starting to get youth into programs to help them become free of the substance dependence that they have become so dependent on, rather than just putting them out of school, giving them more time to vape again. So it was just we help to change policies in that way, and you can do the same thing within your states. Sean, you want to tell them a little bit about the healthcare setting?
All right, absolutely. One of the things, and any of you've worked in the tobacco field may have done some of this. We talk about, doctors oftentimes have very, very little time with a patient, 5 minutes, 15 minutes at the most. So giving them information that they can give to their client on education about things like the harmful effects of tobacco or not using alcohol when you're pregnant, things that make it very easy for them to pass that along to their client. And doing some education with the physicians themselves, because let's be honest, a lot of people, when they think of prevention, they still think back in the 80s about the DARE program or Just Say No to Drugs. They don't know how our field has evolved over the past 40 years. So we can help do that by educating them on the services that we provide and the services that are available in the community when it comes to treatment and recovery, which is that intervention and referral part. Prescribing practices, don't ever go in and tell a doctor how to prescribe to someone. They're not going to respond very, very well to that. But helping them recognize things like the physician monitoring project, and maybe encouraging them to recognize things like, well, is it effective to give someone 90 hydrocodone after they've just had a tooth pulled? Maybe we can start with 10 or something to that effect. We go in there humble and willing to help, but never demanding or acting like we are experts in their field. And then tertiary, we're going to talk about naloxone and needle exchange again, because that is so important. And in healthcare settings, that may be the primary place where individuals go to get naloxone or to get new needles. And then offering behavioral health treatment. I'm not sure what it looks like in other states, but oftentimes even outpatient treatment is very, very difficult to access. My private practice, I've drawn back from it. I don't take as many clients, but just over the past hour and a half that I've been talking to you all, I guarantee I have at least 4 calls on my cell phone of individuals seeking outpatient treatment, because unfortunately it is that high in demand. So helping to advocate for that. All right, now I'm going to turn it over to Sarah to talk about a different setting.
Great, thanks. So workplaces are another place to think about where prevention fits in. So an example of primary prevention for substance misuse for workplaces might be on-the-job safety measures. So if we think about what might lead to opioid misuse, it may have started for some folks when they experienced an on-the-job injury coupled with emotional factors such as potential loss of ability to do their job, which then led to a longer-term addiction. So when workplaces take precautions to prevent injuries, they're participating in substance misuse prevention efforts, even though that might be not what they first think of when they're thinking about workplace safety. Secondary prevention opportunities, training for supervisors about how to recognize the signs, so those screening and assessment type tools. And then when employers offer employee assistance programs and have health insurance that includes treatment opportunities for substance use disorder and mental health behavioral treatment, those are examples of how workplaces and employers can support prevention as well. So as we as professionals, prevention professionals, think about how to partner with employers, we can provide them some education about prevention, introducing them to evidence-based practices, and then also partnering with industry groups or chambers of commerce so that they can play a role in prevention as well. And then communities, I imagine a lot of things may have come to mind for you when I said, what are community partners in prevention? So you maybe feel free to drop some examples of things that you're thinking of in the chat of who those community partners for prevention are. I'm guessing that things like after-school programs or law enforcement, health councils might be coming to mind. So lots of opportunity here to implement many of the strategies that we've talked about throughout the presentation. It's a great opportunity to leverage those community coalitions that you might already be a part of, as well as other community boards or task forces who are addressing related issues. And think big around related issues, because those might be groups working around judicial reform or urban planning or violence prevention. Lots of opportunity for prevention to have a voice at the table if you can be part of those conversations. So great examples coming into the chat of all these different prevention partners that we can be working with. So I think we've talked a little bit, Sean, about some of the challenges facing mental health. I want to make sure that we've got time for folks to ask some questions. Any top of mind points you want to mention here before we open it up to the group?
No, I think I've talked a little bit about this, and we could do an entire day talking about the challenges with the mental health system. Some of your communities are going to managed care. I'll tell you, in Oklahoma, we've got insurance companies that are bouncing checks to providers. So it's a huge mess. But no, I agree. We need to leave time for questions. So I will. Oh, and yes, systemic inequities and racism. I saw someone highlight that. So yeah, I think let's take some questions.
No. Sounds good. So we've talked about a lot today. We started off by introducing the MEB spectrum as this comprehensive framework for understanding mental, emotional, and behavioral health. And we also linked it to some other terminology around prevention, early intervention, secondary prevention, and treatment. So really want to think about how these terms connect to each other and how we really view this as a spectrum of care, that we make sure that we have access to all of these different components and resources for all of these different components in our community. And we gave a lot of different examples about what this work looks like in a variety of different settings. So we need a large group of prevention partners. So want to spend the last couple minutes hearing from you about any questions that you have, as well as would love to have you come off of mute or put into the chat nuggets that you're taking away. What resonated for you today about how you're going to use this information in your work to improve how you work across the mental, emotional, or behavioral health spectrum? Sandra asks a great question. Sean, Derek, I think any of us could take this. Some good examples of how prevention and treatment work together. I'll start off by saying that promotion bar across the bottom of the spectrum, I think, is a great example. So as prevention professionals, when we work on passing policies that create healthy environments that reduce access, that limit hours for bars, that reduce advertising. Those are the kinds of things that can create health promoting environments, which help with what's coming out of treatment. Sean, Derek, anything you want to add?
No, one thing we did here in Arkansas, we saw naloxone education programs, prevention and treatment working together across the spectrum, or to make sure that we had preventionists not only knowledgeable about naloxone, but also emphasizing it to their coalition groups as well, and getting them trained in how to use naloxone and get it distributed, helping to distribute it within the community so that we could save more lives, so that we can do more prevention work.
Absolutely. And remember, there's always ways that prevention can work with treatment providers. You know, if I've got someone in counseling that is in recovery that I'm working on for substance abuse, they have a family. And that family may not need treatment services, but if they have young kids, we may need to do selective prevention services with them.
Right.
We may need awareness on the genetics of addiction, and prevention providers can help with that.
This time, if you've been unable to interact through the chat, if you'd like to open your mic and say something, we'll give you the opportunity to do so now as well. How do you plan to use this information to improve your work? Yeah, I see great information. Really enjoyed the video. Okay, so you'll definitely get a link to that video. Make social determinants of health really understandable. Loved how the video illustrated the entire spectrum, and I hope you'll share that video within your community as well. One takeaway, Rebecca said, is thinking about social determinants of health as risk and protective factors experienced by individuals. These could and might be addressed at individual, community, and the policy levels. Absolutely, absolutely. Okay. Again, it's not over till the paperwork's done. So this, we're going to put a link in the chat as well for you to use this. We want everyone to complete the survey. If you have a smartphone, then you can quickly put it up to the screen and it'll take you to the survey. If not, then we just welcome you to write down that or utilize the link that's going to be put into the chat for you in order to go to it. And let's see, is it there? Yes, it is there. Okay. Also, you should get a pop-up of this as well when you go out. But as long as you've completed it one time, you don't need to do it twice. And unless it's a great review, then feel free to. Just joking. So as we close today, I want to make sure I leave you with this information to contact us. We know that this is a complex subject, and we want to make sure that you know, as a PTTC, we're available to you as a resource, and we can continue to answer questions and work with you and provide you technical assistance in your efforts to work across the spectrum. This is my email address, dlnewby@ou.edu. I'm your TTA specialist for the South-Southwest region. We also have our website that we welcome you to come to our South-Southwest PTT website. And then when you come there, you can join our mailing list and you can find out about all the programs we have coming up. And then we have a whole library for you of products and resources as well. So we emphasize that you utilize those products and those resources and stay in contact with us and allow us to help you grow and expand your services across the spectrum. All the resources that we utilize today and references are here in the slide deck, and you will be sent a copy of this slide deck in about a week. So with that said, we've come to the end of our hour and a half. I know for me, time went very quickly, and I'm sure it did for you as well, but we want to thank each and every one of you for taking the time to come out, and we support you in all your work that you're doing, no matter what part of the MEB spectrum that you're working on. So thank you so much for coming today.